Hi everyone, welcome to researchmd.com. Today we're going to teach you about how to evaluate. If somebody come with a new onset ascites, like what kind of evaluation need to be done. And again, my name is Pramil. Cheriyath. I'm a program director, internal medicine residency, transitional residency, and also I'm a director of research, and I'm an assistant professor of medicine to large medical schools. So let's go into our topic because we have to do all this under 9 minutes. Remember, that's our priority. We want everything systematic done. Okay, so what should we do? When you talk about the definition, first thing we need to know everything we have to define, right? What's the definition? There is abdominal swelling, accumulation of fluid. Pretty simple definition, right? And then you got epidemiology, a few facts, 60th per 100,000 with cirrhosis. So most common, remember, cirrhosis, that is the most common cause of ascites, right? They can have spontaneous bacterial peritonitis, and then second is probably the malignancy, and heart failure and malignancy is kind of together. Third one, heart failure, okay? So etiology, we said like cirrhosis, portal hypertension, albuminemia, malignancy, heart failure, you could have spontaneous bacterial peritonitis. When you look at the risk factors, what are the risk factors? Of course, liver disease can cause what? Cirrhosis, right? Hepatitis B, C, alcoholic use, autoimmune hepatitis, genetic liver disease, hemochromatosis, Wilson disease, and alpha-1 antitrypsin deficiency, any type of malignancy, CHF, and all of those are the risk factors, right? And pathophysiology, when you look at the pathophysiology, there is increased intrahepatic resistance, and there will be increased portal pressure and increased hydrostatic pressure within the hepatic sinusoids and portal vein, collateral vein formation, shunting of blood to systemic circulation, then you got vasodilatation of the splanchnic and splanchnic arterial system, in turn results in an increase in the portal venous flow. Now, let's look at what happens in cirrhosis. Since we said cirrhosis is the most common, first you have portal hypertension that increases hydrostatic pressure, you got ascites, then you got like also decreases the albumin, right? Decreased oncotic pressure, translation of fluid also causes ascites. Then you have aldosterone mechanism that also affect kidney, and your salt and water retention, ascites. Those are the main thing when we talk about the pathogenesis, okay? Clinical features, we talk about distended abdomen, rapid weight gain, abdominal pain, nausea, vomiting. Those are the symptoms usually patient present with. The diagnosis, mainly you can do a history and physical examination, you can do imaging techniques, and you can do paracentesis. So let's look at the history and the physical examination. And when you look at the physical examination, always do the shifting dullness test, right? You put the patient supine, and then you percuss, and then you put the patient on the lateral side, and then percuss, see where the fluid level is, right? Look at the sensitivity and specificity, pretty good. Like, you know, from sensitivity could be up to 94, specificity up to 82%. Now, what are the investigation? You have to do cells count, total protein. So these are like when you do, the first thing when it's like ascites, you have to do paracentesis, right? You look for the cell count and differential because you need to know PMN. We'll come back to that. Total protein. You also have to do the serum and peritoneal fluid albumin, like which is called a SAG, right? You take the albumin, the serum, and then you subtract from the ascitic fluid the albumin. Okay, if the elevated SAG is greater than 1 and the fluid protein of 2.5 gram per dl or greater suggests ascitic due to heart failure. Okay, remember that. So when you have like first thing, when you have the ascitic fluid paracentesis, you calculate the SAG, very, very important. Okay, if the gradient is greater than 1.1, it indicates portal hypertension. If it is gradient is less than 1.1, you can exclude portal hypertension. So if the gradient is greater than 1.1, if the ascitic protein is greater than 2.5, then you have to think about heart failure, pericardial disease, and veno-occlusive disease, okay? If the ascitic protein is less than 2.5, mainly it's like cirrhosis. So when you look at the other side, if the gradient is less than 1.1, then you have to look at the other causes like infection, malignancy, nephrotic syndrome, and pancreatic ascites. So in the serum albumin ascitic gradient, you have a sensitivity and specificity of very high. Look at it, 99 and 95%. So look at this slide carefully again. Kind of tell us like a lot of things about like, you know, how to analyze the serum SAG. Okay. So additional tests, if there's an infection, you can do the culture, bowel perforation, glucose concentration, malignancy, infection, and LDH in malignancy, infection, bowel perforation. amylase concentration in pancreatic ascites or bowel perforation, tuberculous smear culture and adenosine deaminase activity if you're suspecting tuberculous peritonitis, cytology possibly like carcinoembryonic antigen level like malignancy, and then triglyceride concentration in the chylous ascites and bilirubin concentration, bowel or biliary perforation, or serum protein. I mean, you can do BNP like in heart failure. So, imaging technique mainly like first thing always do is like ultrasound, right? And then you have to, it's good to know what are the findings of the portal hypertension also. You got dilatation of the portal vein up to or greater than 30 millimeter. You got dilatation of splanchnic and superior mesenteric vein to greater than 11 millimeter. Reduction in portal venous blood flow velocity. You got splenomegaly, you got recanalization of umbilical vein. So ultrasound, again, remember the gold standard, sensitivity and specificity, very, very high. Come on, 98 to 97%, right? So what are the things you have to do when you have a fluid? Anytime you see a fluid, you know the rule. Put a needle in there, right? So go for the paracentesis. You know, when you look at the paracentesis, there's no absolute contraindication. You know, it's one of the procedures been going on for like centuries. Like people were drinking alcohol, I don't know, maybe like thousands and thousands of years ago, and they were like, you know, walking around with the ascites. Somebody was sticking the needle to get the fluid out. So in the history, it was described so many times before. So the main thing is when you have ascitic fluid, put the needle, get a paracentesis, and look at the mortality. The delay in doing the paracentesis, the mortality increased by like around 3.3% per hour, okay? Remember that. And the other question people usually ask, right, you see the patient liver failure come in, you got an INR like 3.5 or 4.5, you get so scared and say like, should I put a needle? Is it going to make him bleed? Not really, okay? There are studies and the INR up to 9, and they did paracentesis, nothing happened to the patient. So don't worry about it. It's a relatively not a very complicated procedure. Does not cause that much complications, okay? So when you did you did the analysis, the next thing is the main thing you have to rule out spontaneous bacterial peritonitis, right? So the main thing is you need to go PMN and PMN, polymorphonuclear cells, greater than 250. That's the most important thing you have to know, right? What are polymorphonuclear cells? They are neutrophils, eosinophils, and basophils. And you can add mast cells also in there, okay? So those are if it is greater than 250, then you can say they are, I mean, you got spontaneous bacterial peritonitis, then you have to treat it, right? So remember, polymorphonuclear cells. I mean, you have a nice picture on the right side, neutrophil, eosinophil, and the basophils. Okay, so we talk about the spontaneous bacterial peritonitis. Main thing, PMN and cell count greater than 250, okay? And then when you treat, when you look at the ascitic fluid also, you can look at the color. Clear or straw-colored liver cirrhosis, cloudy bacterial peritonitis, perforated bowel, and pancreatitis. Bloody is malignancy or hemorrhagic pancreatitis. Chylous or milk-colored lymphoma, TB, malignancy. Okay, so when you look at the main thing, just to make sure, when you have spontaneous bacterial peritonitis, used to be gram-positive organism. Now there's like a more gram-negative organism also. Make sure you rule that out by looking at the PMN. Thank you so much for watching. This is our references. We'll be back with another presentation soon. Thank you.